Good morning, everyone. It's great to be together in the room in this beautiful Samri venue and share in today's gLocal event together. Really warm welcome to all of you from the different health networks, universities, Department of Health who have joined with JBI today to talk about getting research into practice. On behalf of Professor Zoe Jordan, who's the Executive Director of JBI, and the staff of JBI who have worked to put this event together, we want to just welcome and trust that you have a really great day here today with us in the Adelaide Solution Room. The Solution Room brings people together around a common goal, the goal of developing shared solutions to challenges that we all face in healthcare, whether we're researchers, academics, clinicians, or people leaders in different aspects of health. We're all grappling with questions around embracing quality in the delivery of care. And so it's good that we can come together through gLocal to learn, to discuss, to develop solutions, to partner together in leading or delivering the quality of care, in facilitating and guiding implementation of evidence into healthcare, in doing implementation, and in strengthening the use of evidence in the evaluation of care structures, processes, and outcomes. So there's a lot going on, isn't there? As we start to get into our day, let's begin, of course, by acknowledging and paying our respects to the Kaurna people, the traditional custodians on whose ancestral lands we gather. We acknowledge the deep feeling of attachment and relationship of the Kaurna people to country, and we respect and value their past, present, and ongoing connection to the land and their cultural beliefs associated with land and place. We pay respects to elders, both past and present, and for their knowledge and experience. So where are we going today, right? Maybe you're still a little bit curious about that. So here's what our program looks like. I hope everybody's caffeinated, because you're going to need that coffee during the day, right? I'm Associate Professor Craig Lockwood, Director for Implementation Science in JBI. And today in this solution room, we're going to focus on local evidence-based practice, local experience, and how you bring those two things together. So we have a room full of very experienced people today. It's exciting and a little intimidating, to be honest, to see the depth of experience in the room here today. And so we're going to work with you through a series of core topics around delivery of care and what that looks like versus what could that look like, and how do we reach that point in our visioning for healthcare practice. When we've done that, by the end of the day, we're going to be asking if you want to continue to partner and collaborate on the evidence development and implementation that could be the future out of today's discussion. And if you do think that's interesting to you, we're going to ask you to write down your name and email address so that we can follow up with you and invite you to be co-collaborators into the future on improving the quality of care. So that's where we're going today. It sounds awesome, doesn't it? Yeah. What a program. Oh, I'm excited to be here, and I'm glad you guys are too. So the other thing is, normally speakers go, put your phone away, put it on silent. Well, put it on silent, but don't put it away. We'd love for you to tweet, take photos, and share those on social media. And if you do, please use hashtag JBI Solution Room just to show how trendy you are. And if you're not yet following, get on board. Follow JBI on Twitter. It's not X, it's Twitter. Okay. So get on board with that, and we'll go through that. Today's event is free and open. There are no conflicts of interest that the staff of JBI, or any of our invited panellists need to declare to you today. But maybe some of this is new to you, and you're here, but you're curious, and you're wondering, really, what is JBI, and what is this group on about, and why are we all so connected together around some kind of common interest? So I wanted to take a minute just to give you a snapshot around JBI. We are Adelaide-based. This is home and headquarters for JBI, but we're international. We focus on the development and delivery of unique evidence-based information, so content and knowledge-based content for people, software, education, and training programs that are designed to improve the capacity to deliver evidence-based interventions and to integrate evidence into clinical decision-making. Now, we could just focus on doing evidence, generating evidence, or doing systematic reviews. But our vision has never been to just make or create new knowledge. It's always been to partner with people and groups in order to help knowledge become accessible and useful. And that's why we're structured the way we are. So we're based in Adelaide, but we're global because the goal to improve the use of evidence in decision making is truly global, but it only works if you do it locally. We provide education. We've developed software to help with implementation and research. And we do those things because providing information, as you'll see through today, is not enough. That's not partnership, and we want partnership to strengthen our healthcare systems and the quality of care we deliver. So we do that in partnership, and we do it because we're passionate about improving healthcare outcomes with you. So just another couple of quick slides on JBI and what we're on about. One of our core platforms is the evidence-based practice, or EBP database. My colleague, Dr. Kylie Porritt, who will be getting up to run the Q&A session a little bit later, leads this work. This is really important work to develop high-quality, appraised, summarised evidence so that individuals don't have to spend their time trawling through that other specialist database, Google or Wikipedia, looking for the evidence. It's there, and we have access to it through SALIS. So as the indicator on screen shows, if you're part of SA Health at all, you already have full access to JBI resources, and you may know staff that don't know that could benefit from using some of those resources. So again, you might hear me say it more than once or twice, get on board. Look at how these things can add value to your workspace and place. Equally, if you have staff that are research hungry and want to get involved and are interested, we have research programs such as JBI Summary that help people do systematic reviews, training associated with that, and many resources. And then it's important always to close the loop, right, in terms of where does activity go and how does it express itself. So part of that is in improved outcomes, but if we don't tell the world about that, then no one knows the amazing work happening here in SA. So we have a number of journals also and other modes of social media output that really help shine the light on the amazing work happening here in South Australia. And you may have already seen some of those examples from following JBI on social media. So gLocal, it's a worldwide event. Last year, I can't believe this year's already half over, but anyway, last year over 30,000 health professionals from 17 countries were part of gLocal. Incredible, isn't it? And this year, we have 31 events in 19 countries. So this seems to be snowballing year by year in a really exciting way. And speaking of exciting, I now have the pleasure of introducing our keynote speaker who's going to open the morning session for us. Now, many of you may know, come on up, Karleen, may know Karleen quite well. That's a very polite way of saying Karleen's been around for a while, making an impact on healthcare processes and outcomes. So welcome to the podium, Associate Professor Karleen Thornton with me. Here she is. Karleen's a teaching specialist, academic and academic lead for nursing within the College of Nursing and Health Sciences at Flinders University. Karleen's getting a lot of feedback just now. Bear with us for a minute. Karleen's worked within SA Health public sector for 37 years, of which 20 have focused on the gritty end of leadership, if I could just summarise, maybe by saying that. I don't want to take any more time. It's a privilege and pleasure to welcome you to the stage. Karleen, thank you very much.
Thank you, Craig. Thank you to JBI and for this kind invitation to be able to speak here today. I'm very humbled to actually be here. So just let me get my presentation up. Please don't put your phones away. I want you to have your phones up and out. We're going to use them. And hopefully I can get the technology to work as well today. Now, I'm not a person who stands behind a lectern, but I've written copious notes, and at some stage I might need to go back and look at those, so I'm really scared that I'm going to forget what I need to say. So I do want to acknowledge that we are actually, from a Flinders University perspective, the university is located across many lands, and we want to recognise and acknowledge the traditional owners and custodians of the lands on which our campuses are located. And these are the traditional lands of the Arenta Dagamon, the First Nations of the South East, the First Peoples of the River Murray and Mallee region, Jawan, Kaurna, Larrakia, Nadjara, Narrandjeri, Ramandjeri, Warramungu, Wardaman and Yolngu people. And we honour their elders past, present and emerging. And I especially want to acknowledge the Kaurna people today and recognise that the land that we're on is unceded lands as well. All right, so I'm making an assumption that this morning you had some agency, some self-determination. You brushed your own teeth, or did anyone brush your teeth for you this morning? You all brushed your own teeth? You had a shower. It's freezing cold. Some of you might have had a quick wash, but you had a shower, washed your hair, might have had a shave, gone to the bathroom, got yourself a coffee or a cup of tea, were able to catch a train or a bus or drive yourself here to work, okay, or to this session today. You were able to address your own fundamental care needs this morning, okay? And you didn't have to rely upon anybody to do that for you. You were able to use your agency, make your own decisions about whether you're going to brush your teeth before or after breakfast, have your orange juice, your Wheat Bix or your cereal, or not have anything at all. But there are hundreds and thousands of people that are in care that don't get to make those decisions for themselves. And so they rely upon healthcare professionals to actually address those fundamental care needs for them. And it's really vital that for us as healthcare professionals that we're able to do so in a meaningful and respectful way. But that doesn't always happen. And so what I want to talk about today is a little bit about the things that perhaps aren't so wonderful that have gone from a care delivery perspective in relation to fundamentals of care, and really situate a background that brings us to the point where we are today, and talk about some of the fantastic things that have been undertaken from a research perspective from the International Learning Collaborative, and I'll talk more about that as we go on. So just to set the scene, because we talk about this term fundamental care, and we talk about the fundamentals of care, and we've got the fundamental care framework, but there's some key aspects of this concept, and the International Learning Collaborative have actually put together a very clear definition for us about what fundamental care is. And it comprises some domains, and so one of those that's really important is around the physical needs and the psychosocial needs of individuals who are actually receiving care. And it's underpinned by trust, and it's underpinned by trust in the actions of a caregiver. So we are central to providing the care that those individuals are going to receive. But knowing that we actually work in a system and a context that's going to have policies, it's going to have processes in place by which we need to actually work and abide by. But what we essentially want is that the person is at the centre of all of that decision making. And what's really important is for that person who's actually providing the care is that they develop a trusting relationship with those individuals who are the recipients of care. So some really core, key, fundamental aspects or components of the definition of what is fundamental care. And I do believe there is an article that's going to be used later today that's actually going to talk about the 3 dimensions of fundamental care, which I'll go through when we talk about the framework. So fundamental care is essential. So imagine if you couldn't brush your teeth this morning, you couldn't wash your hair, you weren't able to select the clothes and things that you wanted to put on. Okay, if those decisions were taken away from you, okay, so it's really important that we recognise the importance of those. And I think we take them for granted. Okay, grab your phones, please. I'm going to, if you can use the QR code, I'm now going to activate, so hopefully everyone has got the QR code out. So everyone's got the QR code. Have the questions come up? Yep. So there are 3 questions I want you to answer. It might take you to a 4th question. Please don't jump ahead. All right. So the first question is, who here today has witnessed poor care delivery? So if we look at our first question, who's witnessed poor care delivery? And we can see that 92% of you have witnessed poor care delivery and 8% haven't. So that's a sad indictment, isn't it, around, for those individuals who are the recipients of care, who rely upon healthcare professionals or carers to actually provide quality care for them. So 92% of people have witnessed poor care delivery. The second question was, do you feel you've been able to speak up and be listened to about poor care delivery? And I'm sorry that this is not showing very well. But we're going, 52% have said yes and 48% have said no. And so, 50% of us feel that we can't actually speak up about poor care delivery. It again, that's really sad, isn't it? Considering if we look at the definition of fundamental care, it's about working in organisations that place the patient at the centre. And we may well be working in organisations that aren't doing that. And the third question was, just scroll down, it's always fearful when you try and use technology and you practice at home and then it doesn't come up. Okay, that's the fourth question. Who's jumped ahead and done the fourth question? Save it. All right. So I think we can see we've set the scene around, we've experienced poor care delivery, we've witnessed poor care delivery, and also we haven't felt comfortable actually reporting poor care delivery. Okay, so that's an indictment upon the professions and the healthcare agencies and institutions in which we're actually working. So those are our three questions. So how did we get here? And there's a very long history of which many of you will actually be familiar with. So in 2013, the Mid Staffordshire case was actually brought to the fore. And those of you that are familiar with that, it happened in the UK, would be aware that this report actually really was a sad indictment on the profession of nursing. It really brought shame upon the profession, but it really wasn't the profession's fault. It really was the lack of leadership and the culture within that organisation that led to poor care delivery. And so really that report and that episode of poor care has been the genesis of a lot of research around fundamental of care. And then those of you who are native to South Australia will be very familiar with the Oakden report, and I worked in the local health network in which that actually occurred, and that was quite a significant and sad indictment upon care delivery for people who with dementia within this state, and Bruce Lander, actually the commissioner at the time, handed down a suite of recommendations against individuals and the organisation. The Royal Commission into Aged Care, which happened in 2018, again, that was looking at the care and dignity provided to individuals who were recipients of care within aged care facilities. And then we had the shocking death of Anna Marie Smith in 2020. Many of you will be familiar where she actually died in her home in a chair that she was seated in for days on end. Now, while she wasn't provided care by a nurse, she still was receiving care, and her fundamental care requirements were not being met. So there are really clear antecedents to how we're actually being arrived at where we are today. The impact of those stories can be told and are clear through these anecdotes, and they're not really anecdotes, they are submissions to the aged care report, but also the Oakden report as well. And so these are heartfelt stories. These are people's experiences of what it's like when your care is actually not being delivered upon, when people feel that they're actually being ignored, when their dignity is actually not being met, when they don't feel that they're being respected. There were consumers who were not treated with respect. They were left soiled and unbathed. They were not adequately fed, hydrated, and confronted with a show of force to undertake routine tasks of daily living. That is so, so sad to think that if that was my loved one in an agency that was providing care like that, you wouldn't want that, would you? You wouldn't want that for yourself, and you wouldn't want it for anyone that you love. But this is the realities of some of the organisations that we work within and have worked within. And I tell you, Craig alluded to me being very old, and I am very old. And I trained in the 80s, or I've been around, I trained in the 80s, and I worked on a ward, and just tell me if this happened to you, where we'd get in at 7 o'clock, we'd have handover, we had 32 patients, and by 8 o'clock, all 32 patients, except those that were in traction, had been down to the shower, had come out, all had a white gown on, were all sitting out of bed, their bed was made, and they were all ready for the ward round. There was no discussion about, did you want to get out of bed? What would you like to do? Do you want a shower today? Do you not want a shower today? Everything was schmick. It was schmick, it looked schmick, but there was no person-centred care there. And you think back and gosh, how embarrassing was that I was actually part of that and thought that that was how we provided quality care. And it's not. That was about, doing tasks. So one of the people that actually provided information to the Royal Commission into Aged Care was a lady by the name of Merle Mitchell AM. And Merle was actually, her and her husband made a very deliberate choice and decision to actually go into an aged care facility. And her husband died while she was there. And during that episode, she was actually just told that she just needed to get on with life. Just get on with it, Merle. And so she reported that to the Commission. And down the bottom, and this is an extract of what she actually reported to the Commission, but she said, what sets good staff members apart is compassion. And compassion is something that is so integral to really good care delivery. It's the essence of what we as nurses, and I'll say midwives, actually possess in the way that we care about individuals. And so she said compassion needs to be included as a criteria in the selection of staff. And I know a lot of organisations have gone to values-based selection with regards to recruitment. And certainly after the Oakden incident, within the organisation I worked, values-based recruitment really came to the fore. It's really important that we select the right people to be able to provide the right care for our individuals that are actually recipients of care. And back in 2014, Alison Kitson also was talking about we really need to challenge this concept of fundamental care. And how many of you have heard that, basic care? We do basic care, or nursing, basic, fundamental care is basic. How basic? It's not basic, is it? To be able to develop a relationship with a patient, to be able to do a risk assessment, to be able to link and think rather than just doing tasks by a certain time, that is not basic. And so we need to get rid of that misnomer that care is basic. Care is a very highly valued commodity that we can provide. As nurses and midwives and healthcare professionals, we are highly trained. We're coming out with 3-year degrees and graduate certificates and diplomas and masters, and people are doing honours and significant research. Care is not basic, and so we need to really elevate that. There is a tension within our organisations, I still think to this day, where we talk about task and time and we don't link and think. So the task is I need to get all of these things done by a certain time, and I go in and do the task, but I don't necessarily talk to the patient. I don't do an assessment whilst I'm with the patient. I don't actually do an oral assessment. What's the tissue turgor like for my patient? What's their tongue like? Are they hydrated? Are they dehydrated? Are they drinking? Are they not? Are they able to ambulate? When I take them to the bathroom and actually shower them, what's their mobility and their gait like? Are they actually in pain or not in pain? Or am I just taking them to the shower, giving them the towels and the flannel, and then I come back in 5 or 10 minutes when they've actually washed themselves? And I haven't been able to assess whether they've got the capability to be able to do that for themselves. So task and time is a culture that still exists within some of our healthcare agencies and organisations, and it's something that we need to challenge. And the other is around disaggregated care delivery. And so disaggregated care delivery links really well with this task and time, where we actually don't think about what it is that we're doing as a whole for this particular patient. We'll do one thing but not link it to something else that we might be doing with that for that individual. And so this thinking and linking concept is a really important concept that we need to be embedding within our practice, but giving our staff time to be able to do so. So these are some things that were identified back in 2014, as I said, by Alison Kitson, and anything but basic. So nursing's challenge in meeting patients' fundamental care needs. And the realities of acute care organisations. Now, I've worked in the healthcare sector up until 2022, worked through the COVID experience and was heavily involved in that. But knowing that organisations are really run from a managerial perspective. And so when we're talking about the operationalisation of our organisations, there's some real key parameters that we need to comply with. Activity-based funding is non-negotiable, okay? That is something that we need to actually ensure that we're coming in under the cost, or the efficient cost price. We've also got our hospital-acquired complications. We want to make sure that we're actually not exceeding those. We know our throughputs are monitored every minute of every day. CAT plans always being looked at. You've got flow that are actually ensuring that patients are being moved up from the ED in a timely manner up to the wards. We're sometimes doing fit to sit, so if there's not enough beds, we sit patients out because they're fit enough to be sat out, but they're not yet ready to go home because we may not have discharge lounges in our organisations. We're always looking at, there might be a bed flow meeting at 8 o'clock and one at 10 o'clock and one at 4 o'clock, and then there'll be another statewide one at 10:30 at night if you're lucky enough to be on call. Because the EDs are all red and they're trying to create capacity across the state. And then we had staffing. So who's worked in an organisation where you've actually lost significant staff in the last 3 to 5 years? Yeah. So the COVID pandemic probably exacerbated that for us. So we've lost a lot of experience. And with that comes stressors, and we then lose a lot of corporate knowledge as well. So the clinical experience and the corporate knowledge is actually being lost. People have actually retired, and so staffing then becomes a pressure. You're trying to do the same, knowing that you've got these throughputs that need to be met, but you may not have the same level of experience as staff. And then what happens is we start to miscare. Care starts to get rationalised. We make decisions. We go back to task and time rather than think and link. And so then we make, sometimes when we do that, we actually miscare. And then we might fail to maintain some of those basic fundamental care needs for our patients. Patients might end up dehydrated, malnourished, experience episodes of delirium whilst they're actually in hospital. And so these are the things that we actually want to make sure we consciously avoid. But the realities are sometimes that the system doesn't enable us or empower us to actually do that. So we have to challenge that. This is a true example of what is of being an exec on call. So it was 9 o'clock one night. I pull up into my driveway. I'm exec on call. And I get a call to move a patient from one organisation to another. And as I said, ED is over, well, it's late. ED is over capacity. All the statewide EDs are on red for adults, not women's and children's. The proposed receiving organisation has capacity to take this person, okay? And the focus is to create flow, because I know at 8 o'clock tomorrow morning when I get into work, there is going to be a meeting and questions will be asked as to why we didn't actually move patients around. SAS can do the transfer, I've been advised, and what are you going to do? So I'm being asked for permission to transfer this person from one agency to another. Okay? It's 9 o'clock at night. I'm sitting in my car feeling physically sick of having to make a decision. This person is a 90-year-old lady that they're wanting to move. How do you think we're addressing her fundamental care needs? By putting her up, putting on a barouche, moving her from one organisation to another organisation, regardless of the time. Her dignity, respect, was there clear communication? Was she asked? No. So these are the realities that people are faced with day in and day out. And so sometimes being exec on call was not the nicest thing to actually experience. I want to share with you now a podcast. Now, some of you have heard of Tiffany Conroy. She worked at JBI, worked at the Royal Adelaide, and then worked at JBI and Adelaide Uni, and then has come over to Flinders University. Tiff is an apology for today. She was meant to be here, but I got the gig, so she owes me. But the International Learning Collaborative, which I'll talk about later, has been doing some podcasts around fundamental care. And so Tiffany did her PhD around the fundamentals of care. She did an ethnographic study. And she talks about her experience of observing care delivery while she was actually undertaking her observational work. So hopefully I can get the video to work. And I just want to share with you, it's just a little minute and a half of Tiff's experience.
I was observing care. This was on a late shift, so after dinner one night. And it was on the same ward, and there was an instance, there was a woman calling for help from one of the rooms.
Yeah.
Incessantly, crying and calling for help. And there were a group of healthcare professionals, they weren't all nurses, that were standing in the corridor, certainly within earshot, closer to this woman than what I was, who suddenly burst into uproarious laughter about some exchange that they'd had.
Yeah.
And I just thought, if I was that woman calling for help and all I can hear is people laughing outside, how helpless and how vulnerable would I feel?
Yeah.
But also saw the most wonderful example where there was an Indigenous patient who had a visitor, another Indigenous person with them. The nurse was in there talking and including the visitor. And then I didn't hear the conversation, but the nurse went away and came back with a warm blanket.
Yeah.
But she had one for the patient, but she also had one for the visitor.
Yeah.
Because she recognised that, you know, these people were come from areas where it's much warmer, they feel quite cold in the hospital environment. And so she provided that care and extended that care so that both of them felt comfortable. And I thought, wow, what a simple thing to do, but how meaningful that would be for people.
So it was a very simple act, wasn't it? Just to get a blanket, a warm blanket for a patient and for their visitor. Those simple acts are addressing the fundamentals of care for our patients. And sometimes we just take them for granted. We don't think that they're actually addressing the fundamental care needs of our patients when in actual fact they are. And you can actually access these podcasts via the ILC website. So all of that has brought us here today, and all of those examples and all of those stories and all of those reports and investigations really have led us to be standing on the shoulders of giants. And you are the giants. You are the people who are going to make the change. The giants are also the individuals who had the tenacity and the bravery to stand up and say, we are not receiving the care that we should be receiving. We are not actually being treated with dignity. We're not being treated with respect. It's also those individual nurses as well who have actually stood up and shouted out. If you think about Toni Hoffman from the Bundaberg case, and whilst it was medical, she stood up and fought and fought and fought to ensure that the care needs of patients were actually being treated. So you are the individuals, you are the giants on whom fundamentals of care is actually going to rest upon, and our patients as well. But you'll see there are 3 individuals up here on the screen as well. So Professor Alison Kitson, who was in the video with Tiff. Alison is the chairperson of the International Learning Collaborative, and Alison is prolific and passionate around fundamentals of care. She is an exceptional researcher in this area, and just to listen to her is so awe-inspiring and just phenomenal. So Alison describes herself as a proud Northern Irish woman who also worked at the JBI as well, so there's a nice legacy here with the strong connection, and worked at Adelaide University before coming to Flinders as the Executive Dean and Vice President for the College of Nursing and Health Sciences. The second person, Tiffany, who you just saw before, is also a prolific researcher around fundamentals of care and very passionate about advancing this, and is also on the International Learning Collaborative Management Committee with Alison. And the third person I've got up on the screen is Dr. Rebecca Fio, and Rebecca is very well published as well and does a lot of research around fundamentals of care, and has developed a whole range of tools that we can use from a leadership perspective to ascertain how well embedded is fundamental care within the care delivery we provide, but is also in the throes of actually developing a tool that educators can use to understand how well fundamentals of care has actually been embedded within educational curriculum and workshops. Those 3 key people are currently in Oxford at the moment, okay? Because the annual conference for the International Learning Collaborative, which is the 4th or 5th dot point on the screen, is having its annual conference, and every second year it goes back to Oxford. Now, the International Learning Collaborative has its genesis as it's linked back to the Mid-Staff report, and they identified that they were going to make a stand around fundamentals of care, and they've got a global vision around transforming care, which links nicely to the global and local that Craig talked about before. The International Learning Collaborative has members from all over the world, and certainly the Management Committee has members from Denmark, has members from the US, New Zealand and Australia as well. And so the International Learning Collaborative is the preeminent organisation that's focused on promoting fundamental care delivery. Situated here within Adelaide, so some nice synergies again with the JBI, but certainly has a local impact, but also a global focus as well. So these are the giants upon whose shoulders we actually get to stand, which is absolutely amazing and fantastic. So one of the things that the International Learning Collaborative has done is provided us with some resources around fundamental care and about what it looks like to get fundamental care right. And they've actually developed a fundamentals of care framework. So I just want to show you a short video on why fundamentals of care matters. And again, hoping that I can get, yep.
As clinicians, how to provide fundamental care to patients might seem like common sense. Caring for others drives us. We do it every day. But knowing how to best care for patients is complex and challenging. What does quality fundamental care look like in today's health environment, where we have to make hard decisions about managing limited time? Research shows patients' fundamental care needs aren't always addressed, sometimes with devastating results. The Fundamentals of Care framework identifies and guides healthcare providers to get fundamental care right. A walk isn't just a walk. It's how we connect with patients and assess mobility. By helping a patient eat, we build relationships, assess swallowing, promote socialization, and ensure proper nutrition. This integration is what fundamental care is all about. The Fundamentals of Care framework describes how best to deliver relationship-based, integrated fundamental care. Since being developed in 2012 by an international collaborative, nursing leaders and consumers have been working together to apply the Fundamentals of Care framework to practice. The Fundamentals of Care framework is about building relationships and developing trust. It integrates all components of care, physical, psychosocial, and relational needs, within a larger context whether in acute ward, an aged care facility, or in a person's own home. Fundamental care isn't easy, but it's essential to well-being. The Fundamentals of Care framework guides the care you give to ensure no fundamental care need is neglected.
And so you can go on to the ILC's website and you can actually look at that as a resource. There's a whole range of resources there that you can actually view. So this is the framework, and some of you may have already seen this and been familiar with it. So that cartoon sort of image and representation has now been published, and this is the latest iteration of that Fundamentals of Care framework developed by the International Learning Collaborative. And if you think back to the definition that I spoke about at the start of what fundamental care is, you'll see that in the middle here, the relationship, and it talked about a trusting relationship. So there are three key dimensions to this framework identified through those concentric rings, and the relationship is what you and I as healthcare providers will actually establish with the patient that we're actually providing care with. And it requires that we have trust. We develop trust with those individuals, we focus on them, we acknowledge them, we get to know those individuals, okay? And we really evaluate where they're at within their care delivery needs at that point in time. The next outer ring is addressing the physical and the psychosocial needs of our patients or those individuals receiving care, and it's actually underpinned by the caregiver actions. And so they're the actions that we actually need to put in place to be effective and provide that care for these individuals. And so there are things like being empathic. Okay, when we talked about Merle Mitchell and her submission to the Aged Care Commission, she talked about compassion. And so very similar here, that we are required as healthcare professionals to be empathic, to help patients cope. And you can tell I can't see this or that, and so I need to look here because I'm so blind here with my glasses on, I'm sorry. We need to actively listen. We need to help our patients to stay calm. These are skills that we need to learn as well. We need to be present, we need to be compassionate, as Merle said, and we need to work with our patients to set goals. So that requires us to have established a relationship with our patient, and then these are the actions that we need to actually enact each shift, each time we're interacting with these individuals, so that we can actually deliver and enable them to actually have their psychosocial and their physical needs met. And you can see them on the screen. So the psychosocial needs are things like being involved, being, engaging in communication, having that respect, their dignity, privacy. I remember, it's all about anecdotes, many, many years ago when HIV was prevalent, and I was working in a 6-bed bay at the time as an infection control nurse, and the prof came up and gave a gentleman, I don't know why I'm looking at you, Scott, look here, gave a gentleman a diagnosis that he was HIV positive, and there were 5 other men in that bay. Where's the privacy? We now move to single rooms, and so that addresses some of it. But, some of those things we just don't do and didn't do very, very well, and we still don't do very, very well as well. The other is around then addressing people's physical care needs. So do they get enough rest and sleep? What's a ward like at night duty, on night duty? Do we turn the lights off? Do we not be quiet? Oh, someone just said no. No. So it's about how much rest and sleep do we actually give these people. They're ill, they're not well. Personal cleansing and dressing. How many of your patients always get a flannel after they've been to the toilet or used the bedpan or a urinal in your ward or your hospital or your areas? 100% of the time? No? That's a basic care need. Would you go to the toilet and not wash your hands? I wouldn't. Medication management, toileting needs, helping people to go to the toilet, eating and drinking. I don't know about you, but I can't take the little peel-off things, and you get a popsicle stick to stir your coffee with, and your toast is cold by the time it comes up from the kitchen. All of these things are about addressing people's fundamental care needs. Do people feel safe? Are they comfortable? And are they able to mobilise? So these are the things that our actions are going to enable people to actually have those needs addressed. And then the outer ring is around the context in which we work. And if you think back to the Mid-Staffordshire example, this is where the system didn't work for those nursing staff and for those patients, because they didn't value patient-centred care or person-centred care. They didn't value the fundamentals of care that our patients actually required. And so you need to have a context of care that's got a great policy, a strong policy level, that where it positions patients at the centre. So rather than being exec on call and getting asked to actually move a 90-year-old at 9 o'clock at night, if we had a patient-centred approach to care delivery, would I have got that call? Probably not, okay? And we have a strong focus on safety and quality, and there is governance, clear governance and accountability. But on the other side, do we have the resources? So we know that we've been working in an environment where we actually don't have the same level of staff that we've had before, okay? And do we have strong leadership? So is leadership actually driving the way and saying every decision we're going to make is around improving the quality of care for our patients? Okay, so that's a challenge to all of us to be able to actually promote that. And it gets back to culture. What is the culture in your organisation? Is it a patient-centred care culture, or is it a culture around KPIs and bed flow that's actually driving what you're doing? All right, so they're the things to think about. So this is the fundamentals of care framework, which is great. You know, you've got all of these key aspects, we've got the dimensions, we've got the elements. But what do you do with it? Because you can take it and you can give it to a group of nurses, you can give it to your teacher or Ps, or you can give it to your second and third years, or your clinical nurses, or your nurse unit managers, or your nursing directors. Do you think it's going to help them? So it's a piece of paper at the moment. It needs to be lived. We need to actually translate that into practice. And so it's really important that we do so. So there are a range of ways by which we can actually do that. And again, the International Learning Collaborative has been really, really prolific in this. But I want you to get your phones out again. Hopefully you've still got them. Some of you have already answered this next question anyway. So remembering these three dimensions of relationship, integration of care, and context of care, okay? The next question is, what aspects of the fundamental of care framework do you believe is the most poorly implemented? So I've got 44% for relationship, 36% for integration of care, and context of care is 21%. I wish I knew how to get this on the screen, but there we go. So nearly half is around the relationship. And the relationship is so important, because you are the ones that are going to be connecting with those patients, those individuals. But interestingly, we've only got a smaller amount, half again, around the context of care. And in the mid-staff case, it was the context of care that let those nursing staff and patients down, okay, because the culture wasn't there. There wasn't a patient-centred care culture with that organisation. All right, but there is a care revolution occurring. Now, we've been doing things within fundamentals of care from a research perspective and looking at this since 2013. But this is a very deliberate and intentional approach to actually revising and revolutionising care delivery, not just here in Australia, but also internationally. And across these three journals, there have been 75 publications around the fundamentals of care or the application of the fundamentals of care framework. So those giants that I had on the previous page have been quite prolific and working with other individuals to actually ensure that we're getting this practice into research, and then research is again informing practice. So there are three key documents that were published since 2019 across these three journals, and I'm going to talk about them, and they've emanated out of the annual conferences that the ILC has actually held. So there's been three conferences. Back in 2019, the conference was held in Aalborg, and they actually published and identified that there were 5 key aspects that they thought that we should be doing, and I'll talk about these in more detail. In 2022, the Oxford Statement was actually released, and it was around No More Heroes, and I'll provide some context to that when I talk to it. And in 2023, last year, in Maine, there was a position paper released around the fundamental care revolution that was actually needs to happen within healthcare. And so the Aalborg Statement has 5 key components to it. And this is things that the authors of the paper were saying, this is what we need to do to be able to revolutionise or to actually elevate fundamental care delivery for our patients. We need to value it, and it needs to be valued. At the moment, how many of you are going to meetings? Lots and lots of meetings. Yep. And are they all around patient-centred care? Are they all a good use of your time? You know? So we need to be thinking about how are we valuing the time that you've actually got. So we need to make sure that fundamental care is foundational to all of our activities and our systems and our institutions. Is your institution placing patients at the centre of all care decision making? Okay. We need to talk about fundamental care as well. Okay. So what does it actually mean to provide fundamental care? What does it mean when it doesn't look right? What are those experiences for our patients? What does it look like at all levels across our organisation? So we often think about care delivery as the remit of our level 1s and 2s and 3s who are out the coalface. But we've got 3s and 4s and 5s who may not actually be at the coalface, but are actually going to be quite influential in providing and influencing care delivery, about how our staff are educated, how the staffing occurs, policies and procedures. So we need to value and talk about patient-centred care. Then we need to do it. Okay, so it's great we can talk about it, but are we doing it? So do we actually have wards and areas which are actually elevating fundamental care delivery and really celebrating the successes that they're actually engaging in? The other thing is around owning it. So if you don't know about the fundamentals of care, and then you don't know about the fundamentals of care framework, I would encourage your staff to do so, to be more aware of it, so that they can own it and understand what it means to actually deliver fundamental care and what the requirements are to do so. So to actually own this at an individual level, but also at an organisational level as well. And then the research that actually underpins fundamental care. And so each and every one of us has an opportunity to be engaged in research. I know that the universities have got joint positions with most of the LHNs, and so fundamental care could be a priority with regards to research in those particular areas and partnering with JBI as well. So we need to make sure that we can deliver on all 5 of those, that we're actually actioning those. And so that was the Aalborg Statement from 2019. The following statement in 2022 was around no more heroes. And you might think, well, what does that mean? So this statement came out, and there was a little hiatus because of COVID. There wasn't a conference between 2019 and 2022. So in 2022, you'll remember we're just getting towards the end of the COVID pandemic. And if you remember, a lot of our society would stand on the side of the roads and they'd come out and clap our nurses. And we just saw visions of that. And people would really celebrate nursing staff and midwifery staff and any other healthcare provider at that point in time. But this paper specifically talked about, during the COVID pandemic, nurses and other healthcare professionals stood up and did extraordinary things. It's like they had capes on. You know, if you recall, you know, the hours that you worked, the things that you did to actually ensure that your patients were cared for, okay, were almost lauded as heroes. And what this paper was saying was nurses and other health professionals shouldn't have been lauded as heroes because the system should have supported them to do these things in the first place, okay? And then what the paper then went on to say was, well, actually then it became a bit of a turn because nurses were actually seen as people who were gatekeepers. We were also ones promoting vaccinations, visiting times and all those things. So we had been, you know, these heroes, and then we moved to the other side. So this paper is about that should never have happened to the workforce. And what should have happened was that system, that outer ring of the policy and the system supports should have been there to ensure that patients actually received fundamental care at that point they actually needed it, and nurses shouldn't have had to stand out and worked extraordinary hours through extraordinary times to ensure that patients received that care that they did. And so this paper is saying that fundamental care needs to be the minimum standard, not just in extraordinary times, but every day that we come to work, that this is actually provided to patients. And as nursing leaders, for those of you who are nursing leaders in the room, stand up and actually call it out. So when the organisation is not enabling your staff to deliver fundamental care, call it out. Okay, challenge it. Sounds easy, I can sit up here and say that. But, you know, those of you in the room, this is a challenge to you as well. And the other thing is that the voice of nursing leaders need to be heard and not squashed, okay? So that our nursing leaders actually have an equal voice at the table. And if you're going to talk about care and care delivery and nursing practices, nurses need to be at the table. So nothing about us without us, nothing about patients without having a nurse leader at that particular table, okay? So this is the time the ILC was saying, we are going to step up and we're going to really have a voice in this space, okay? We're not going to be quiet, we're not going to be these heroes, we're really going to own fundamental care and we're really going to advocate for our patients, okay? And then the last statement that came out was last year, when the last conference was in Maine, and this was about time for a fundamental care revolution. And Alison Kitson is the key author of this particular document as well, this statement. And there are 4 actions that this position statement talks about, and they are address non-nursing tasks. So how many of you do tasks that are not nursing related? A couple of you, right? Yeah, all the time, yeah. So we need to name it, and this is where the leaders need to come in and actually say, my staff are doing non-nursing tasks. If they could actually be better directed to providing direct patient care and addressing the fundamental care needs of their patients, we'll get better outcomes for our patients. So we need to be able to advocate for that. We also need to accentuate the positive. So I've started today, and I'm very, very conscious of this, that I've started today's presentation around the background and the historical antecedents that have led us to this, which are very, very sad and a sad indictment upon our profession in healthcare per se, or overall. And I've done it intentionally, but we need to accentuate the positives. So the positives that have come out of those adverse outcomes, the positives that are happening on your wards, the positives that your leaders are actually implementing, the positives that might be occurring within a policy framework that's occurring as well within your organisation. We need to be able to access evidence and assess the impact, okay? So there is a lot of research that's being published. As I said, 75 articles across those 3 journals around fundamentals of care, and also the implementation of the fundamentals of care framework into practice, which you can actually utilise. And we also need to advocate for interprofessional collaboration. As nurses, we are there 24 hours a day. We are the glue that hold the healthcare system together, okay? We do not work in isolation. We work with other healthcare professionals, so we need to bring them in. 1 minute? Oh, okay. Goodness me. All right, so this is about working together. Alison Kitson sent me this email last week, and she was travelling and she was going to Torino, and she heard a fantastic example where fundamentals of care was introduced into a ward, and they were going to evaluate the impact on staff and patients compared to when they weren't implementing it. But they had a great dynamic and relationship with their medical staff and their nursing staff. So we think local and we're acting globally. So this is a great example of that. So clinical leadership is so important to the delivery of quality fundamental care. I feel really pressured now. I want to talk, there is a great project up in Queensland, if you get to have a look at it, Eat, Walk and Engage, where up in Queensland they actually implemented the fundamentals of care framework, and they reduced the incidence of delirium by 47%, okay? So, and it's been published, so you can have a look at that. So what are your next steps? My questions to you. What are you going to do to promote fundamentals of care within your organisation? What are you going to do and take back? And think about what supports do you need to be able to be successful? What resources are required within your organisation? And what evidence is there available to actually be able to support you to implement fundamentals of care within your healthcare agencies? The International Learning Collaborative, you can grab it online, come and see me after. But I just want to thank you. I want to thank you for being here today and being a giant whose shoulders we're going to stand on. I want to thank you for giving care to those patients who have actually come in and received your care, and to their families and loved ones as well. It is an immense responsibility, okay, and I want to thank you for also nurturing and guiding the new nursing workforce of the future, for those of you that are out working clinically and you take students from a whole range of education providers, and I want to thank you for investing in your future colleagues as well. That's it, and there's my references.
Stay here with me for a second.